So, good evening, everyone, from London to our latest webinar in the long series of webinars supported by Surgery International. As you know, the last 2 years, we set up Surgery International to build a community of surgeons globally. We now have over 22,000 surgeons connected through our platform to discuss the latest innovations, the latest trends, and of course, the latest technologies that are evolving around the future of our noble profession. We are delighted to have an amazing panel here today to talk about the next steps of robotics. Last year, we had an amazing panel around talking about the here and now of surgical robotics. Today, it's about what's next, what's on the horizon. We've gone from analog to digital over the last few years, and 2025 for me is the world of digital surgery, the connected healthcare system that we all crave, the kind of AI-driven pathways and analytics to assess people's performance going forward. The OR will change immeasurably over the next 12 months, and robots are certainly part and parcel of that change. It's exciting, of course. And so here to discuss this, we have an amazing panel who I will introduce shortly. So thank you for joining us from around the world. We have over 500, I think, registrations from consultant surgeons from many countries across the globe. So thank you for joining us once again. Okay, now to my panel. Mark, do you want to introduce yourself first of all?
Hi, and thanks for joining us, everybody. Shafi, thank you. I'm Mark Sack. I'm the co-founder of CMR Surgical, and before that, I was head of gynecology at the Cambridge University Teaching Hospital.
And thank you for joining us, Mark, and thank you for always supporting our platform over the last 24 months. Rob, you're on my left next.
I'm Rob Morgan, VP Medical at Scientia Innovation. We're an innovation and product development consultancy helping our clients work on the what next.
Thank you. Thanks for joining us, Rob. And Rebecca.
Hi, my name is Rebecca Cleary. I'm the CTO and co-founder of NAMI Surgical. We're trying to bring an ultrasonic device onto a rested robotic joint.
Thank you for joining us, Rebecca. And last, my name is least, Stuart.
Hi everyone. I am CEO of Think Surgical, which is a orthopedic robotics company. Prior to that, I spent a lot of my career working for Stryker, who are one of the large medtech companies. And in that time, I got involved with robotics through the acquisition of Mako. So possibly the odd one out here in terms of being hard tissue robotics, but I'm really looking forward to the conversation. And it's nice to reconnect with Rob because the Surgentia team helped us with the development of our Think Surgical robot.
Great, thank you. And we'll delve that much deeper as we go forward. Okay, so look, we are now, of course, and I always say this, we're at an inflection point of medicine. Things are changing so rapidly, and COVID precipitated many of our innovations, allow us to adopt new technology much faster, and surgery is evolving at a rapid pace. So I'm going to Mark first of all. Now, Mark, you've been running this company, CMR Surgical, for almost 2 decades now, I imagine, right? You've seen the rise of your robot, building it, developing it, deploying it across the world. So let's get your insights of a existing kind of one of the market leaders, I guess, around what do you see happening in the next 5 years that you can share with us, in the sense that what do we think is going to happen? What should we expect from companies like CMR and others? Now, I think last time I read, there's over 110 robotics companies in the world, maybe more.
Companies, yeah, 110.
So, Mark, give us your thoughts on the next 5 years.
So, yes, it's been an interesting journey. We ourselves are now the second largest soft tissue robot company in the world. We've been around since 2014. I think the big change is I think we're starting to see surgeons adopting robotics now. And I think we're at the inflection point up until about 2019. The overall picture in the world is that it was really the innovators and the early adopters that were using robots, and it hadn't got through to the early majority. And I think when I'm seeing people reach out from much smaller hospitals, non-academic hospitals, really wanting to place a robot, then I think we're getting to that point where we are moving towards the widespread adoption of robots. And also, in the beginning, you wouldn't have got me ever to say that a robot was better than a skilled advanced laparoscopic surgeon, but we are now starting to definitely see evidence of improvement of the surgery as a consequence of adopting a robotic platform. And of course, the other big thing is training. I can train a robotic surgeon to competence on a robot for MAS far faster than I can train a surgeon to competence in straight stick laparoscopy. And the good example there is suturing, tying a knot. If I took an amateur, it'd probably take them 50 or 60 hours to learn to do it properly, if they ever learnt it. Whereas in the robot, I could probably teach most amateurs to tie a knot in about half an hour.
Wow.
And that will have massive implications for training. So you truncate training, increase the use. So I do think we're at that point when you're going to see widespread adoption that will drive down prices, that'll make it more accessible. And so that's where I'm obviously both hoping but wanting to go forward, because I really think if I was still an active surgeon now, I would not want to be doing straight stick laparoscopy. I would be wanting robots to go forward.
Thanks for setting out the landscape. I think I absolutely agree with you. I think the kind of the genie's out the bottle now. You proved the point. It's in now. It's in practice. Question how we deploy it, how we scale it, and ultimately how we democratize it. And we will talk about that later in the webinar. Rob, tell me your thoughts for the next 5 years. What are you thinking?
There are some maturing market segments or areas of clinical practice, and they're represented on the call. So the Versia system that CMR has for soft tissue surgery, the T-Mini system that Think Surgical has in orthopedic surgery, those are maturing segments. But one of the things that we see, and we have a sort of privileged position of working for many different companies in surgical robotics and working on many new technologies, is we're seeing a diversification in the systems and systems being developed for much more specialized applications. So there are some really emerging areas of robotics which are not accessible through the existing systems. So in ophthalmic surgery, very manipulation of very, very small instruments in ophthalmic surgery, structural heart, thrombectomy in treatment of stroke, percutaneous delivery of probes for interventional oncology. I think we'll see specialized robotic systems being developed for these applications, and the clinical uptake increasing in the next 5 years.
Lovely. So diversification, new market areas coming in, new areas of specialty, for example. As we know, it's mainly been urology, gynecology, and colorectal has been the mainstay. We're now seeing other specialties now coming in and using robots for their own use cases. So we've gone from a kind of one of the largest providers of robots in the world. Mark mentioned he's now second on a global level. We now go to a startup at the beginning of their journey. Rebecca, tell us more about your company and what you're trying to achieve. You're spin out from Glasgow University, I understand. And what do you as a company, new to the market almost, expect in the next 5 years? We'd love to hear that.
Yeah, thank you very much. That was that nice introduction and a question that I think I'll be able to answer. So I can definitely pick up where Rob finished off, and I think part of that diversification and the need to have something special also translates into what the surgeon needs in their toolbox. And I think there needs to be every tool that's available in open and available in lap is also available on the robot's wristed joint. And that's where NAMI comes in. So we've managed to miniaturize ultrasonic technology that's had years in history and laparoscopic onto a side where it can be put on the distal end of a wristed joint. So down to that, through the trocar with that degree of freedom that we know surgeons require and allows them to perform more precision surgeries. And we want to be part of that curve, because what we also would like to be, and I don't want to jump ahead on our topics, is we want to add to the data that's generated in surgical robotics to give the surgeons the data that they need to then correlate towards patient outcomes to then what we see as a good surgery and maybe one that requires improvement for next time. We believe we can be part of that.
Thank you. And your instruments that you're creating, what was the barrier before for them being developed? What's your secret sauce? And what are you hoping to do with this new technology?
Yeah, so our secret sauce is in our IP, but what I can say is our ultrasonics are always designed based on their geometry. So the straight stick or the long waveguide has always been part of its functionality, not just to allow the access through the port. We've managed to take that straight stick that's about 30 to 40 centimeters long, then you add the blade, then you add the transducer at the back. We've managed to take that full system down to being 5 centimeters in length and at the moment approximately 6 millimeters in diameter, so suitable for an 8 mil trocar.
Amazing. And when do we see that being deployed, do you think? Give us a time frame. Can you share that?
I'll go for 3 years.
3 years. So that's your 5-year time frame. That's pretty good. And then, of course, you can sell to Mark at CMR at your kind of instruments, right? Okay, right. Now to Stuart. Tell us about you're like the elder statesman with Mark, I guess, in the world of robotic surgery. You mentioned you'd worked on the Mako before and Stryker. So you must have great insights. I'd love to hear more about your thoughts around the next 5 years.
Thank you. I'll pick up on one of Rebecca's themes. I do think that form factor and miniaturization is a big part of the technology evolution that we're going to see in smart instruments and robotic systems in totality. When I look at the orthopedic market, particularly joint replacement, there's been quite a rapid adoption of robotics for total knee replacement. It's because the knee is a very complex joint, and to deliver a good outcome for each individual patient requires a level of sophistication that isn't necessarily always available through manual instrumented surgery. So that's why about 20% of all knees in the United States are now implanted with the robot, and the growth curve looks like it will continue for many years to come. But the robots that are on the market today are traditional robots, big base units, robotic arms, and then an end effector on the end of it, and they take up a lot of room in the operating room. They create a lot of disruption in OR workflow, not just for the surgeon, but for the operating room staff. And in actual fact, all of that equipment is not necessary to deliver the surgical objectives. So what our company has done is we've, working with Rob's team at Sagentia, we've developed a product we call T-Mini, and it's a handheld wireless robot that performs all of the same functions that you would find in one of the large format robots, but in a small 7-pound handheld device that doesn't disrupt the operating room at all. And it's kind of designed from the surgery backwards rather than from the traditional notion of a robot forward. And I think there's going to be a lot more form factor innovation in robotics, which will make them easier to use, less expensive overall, and easier to adopt within various different surgical procedures.
Great. Super exciting. Miniaturization, kind of you're going to create things that are much more ergonomic, smaller, more sleeker. I think it's super, super exciting. So look, one of the things that it would be a shame not to talk about in this webinar, of course, is the whole world of AI and data and analytics, because obviously what robots offer over and above analog surgery or laparoscopic surgery is the amount of data they could collect potentially, which could then be utilized to maybe assess performance going forward. I'd love to hear your thoughts around what that data could look like. How is it going to shape the future of surgery? And we'll start this time with Rob. Let's talk about the data analytics in robots. What does that mean? Is it relevant today? Are we going to see the implications of that in the near future?
So there are many different use cases, and I think that's a really good place to start from, is to talk about the use case. And one of the ones that really interests me is assisted decision making during the procedure, in a way that can be shown to be safe and efficacious and can be approved by regulators. And so decision support is quite a good way of thinking about that. It's the system using existing data or data that's being collected through that procedure and combining the data streams, and using the data analytics to give a prompt or give a guide in terms of procedure and workflow. And that can be to improve outcomes or improve the procedure. It could just be to, in the first instance, to reduce cognitive load. I mean, I think about, I'm not a surgeon. We have many surgeons listening, but if I make a simple analogy, I mean, when I'm driving, I'll sometimes have Google Maps on when I know the route. I'll know the route quite well, but I'll have Google Maps on to remind me where to turn off, just because it reduces cognitive load for me. So I think that that use of data and data analytics in that sort of decision support context, that use case is interesting. And just to add a little to that, where advanced technology comes in on the hardware side, in addition to the analytics, is where you can sense additional data during the procedure. So new technology for sensing critical structures, feeding in live data streams, which can assist in to continue that analogy, to assist in filling out that Google Maps for surgery.
Yeah, and we talk about surgical navigation as being the future, Google Maps. Now, I often talk about surgeons having three qualities, which is the knowledge, the judgment, and intuition. All three are hard to be objective about. It's subjective kind of knowledge over many, many years. But the question is, how do we overcome some of that, which it causes errors, causes some, I guess, that we could do better with objective data to enhance your performance both during and after the operation. So I totally agree with you in that sense, how decision support would be greatly supported going forward. And the whole OR, remember, is becoming more digitalized. I have seen people now having dashboards, having cameras now, using computer vision, assessing people's performance during the operation, the whole team working, for example, kind of to work out how we can improve the flow across the theatre, for example. So it's super exciting. So talk about data. Obviously, I guess, Rebecca, as a startup, as you're collecting all this data, you're right in the space of saying, how do we as a company make sure that we future-proofing ourselves by collecting data that we can utilize going forward? I'd love to get your thoughts on what you think about that.
Yeah, I mean, yeah, it's day to day for us. So every day we go into the lab with what is a very rudimental piece of technology right now. There's no robotic arm, and we capture lots of data, and we try to have as many of our members of staff operating the device and then watching the data behind it we're capturing and how it's currently driving to then analyze that. And I guess what is happening right now in like the most advanced systems is something not dissimilar, but to a much higher scale. They're capturing an immense amount of data, which they're trying to correlate to improve the outcomes on the other side. We're doing the same. We've got our tool, it's very rudimental. Our control algorithm is hugely important, and we're then adapting that to ensure as we operate our device, it becomes stronger and stronger. And I think as we progress towards, and I would never say this within the 5 years, but the automation of ones, that semi-automation, that kind of operation like game that people played of pulling back when they're about to touch a structure that they're not supposed to, becomes really, really important for that when that data comes in.
Yeah, I'd love to see how that could prevent errors, make us more accurate, make them safer going forward, because that's kind of where we need to be. Mark, CMR, you deployed hundreds of robots now across the world. You're collecting lots and lots of data. What are you doing with it?
I'd say, just to follow on from Stu's point as well, is we are the one differentiating robot because we don't have a large form. Because of our unique wrist, we have a very small robot, which is not even 5'7" tall, and its bases are 38 by 38 centimeters. And so it integrates into the workflow. And we have specifically designed the robot to replicate good laparoscopic surgery. So same port position, same procedural steps, etc. It's actually very important. But from the very inception, data has been, I'm a geek and I love data. And from the very first patient we did, we've had a registry, which I analyze with control method analysis. And no, I'm just staring at a paper that we're about to write with 7,000 patients in it. We'll do another one later in the year with 22,000 patients in it, and then another one with 30. And that data is also linked to my telemetry. So all telemetry is taken up to a cloud. We have every single telemetric record since we begun, and we have all our videos because they are also automatically uploaded, and we've got it all anonymized. So if the scope comes out of the sheath, it switches off the camera immediately, so there's no non-anonymized data. Now that all starts being put together as a potential data package for analytics and so on. And with a 99.9% accuracy, my robot can tell from telemetry and hand movements, can tell the difference between a novice and an expert. So that just gives you a glimpse of the future. Perhaps a surgeon coming to do the annual appraisal will sit down at the robot and the robot will give an assessment of how fluid they are on the robot. It also, when training, you could take your video, Shafi, and you take mine, and we can compare the two videos. I might say, Mark, in step 5, you're using 100 more hand movements than Shafi, or you're doing, and then we can analyze that video, part of the video, and maybe improve. So it's got continuous learning process that's coming back into it. And of course, we want to things like predictive analytics. When you want to fire your diathermy and you can't see the instrument, for it to say, you can't see me, so don't fire now. And we've had some real-time examples already when there was a disagreement in a theater between the surgeon and the assistant as to who had created the injury. And I was able to go back, look at the telemetry, and actually precisely say what had happened. You know what I mean? So it's I just get there's so much to do still, but I do get excited about what that's going to do for us, and so we are very much working towards having aids, and as you say, reduce that cognitive load. But I also always jump back to one bit of common sense. I always say, imagine if you had an AI system that could reduce complications by 47% and deaths by 35%. How much would you pay for it? And ironically, we do have such a thing. It's called the WHO checklist, and it costs nothing. So let's not forget about doing the basics correctly as well, while we do these rather exciting things. But I find the whole data, the digital, and the other thing about digital is we're a digitally driven robot. So if my surgeons say they don't like the way the hand controls work, we just change it. And every 6 months you're upgrading based on what the feedback you're getting from the field. So it's going to show speed that we've never really seen before in instrumentation and systems.
Thanks for that explanation. Super smart. Really excited by that whole prospect. And yeah, as a surgeon for the last 33 years now, I've been in clinical practice. We've kind of gone through incremental changes, and this appears to me to become exponential change, very quick, very dynamic, and something that's absolutely necessary in our profession. Stuart, coming to you in terms of the orthopedic side of things, you mentioned you're doing kind of robotic surgery around that area. Are they collecting data in orthopedics and other areas? Are they utilizing it? How are they using it to enhance the practice?
Well, we're in orthopedics at orthopedic robotics. We're in the earlier stages, I would say, in terms of some of these initiatives. But I like to think about the intelligence generally when we talk about information and what it's used for. And while I completely agree with what Rob said about decision support tools, the more the system ingests information and learns, the more decision support it can provide. And I also think about it in terms of if you like, game tree type of intelligence where you can teach the system to respond to the surgeon, which is what we've built into the T-Mini. It predicts the next steps in the procedure based on the actions that the surgeon takes. And that leads to great efficiency in the surgical procedure. And I think that is an area where we'll see a lot more development. And the third thing in orthopedics is the most important variable in any surgery is the surgeon. And during a surgery, an orthopedic surgeon might make dozens of decisions in the operating room, some intuitive decisions that are based on their training over many, many years, and some deliberate decisions where they stop and think and make a decision. But most of those decisions, if not all of them, are lost and not recorded in the operative note. And those decisions probably have a profound influence on short-term or longer-term outcomes. And with a robot, you record each of those decisions or many of those decisions. They're in the log files, the session files. And as we capture those log files and upload them, eventually we'll be able to tie them to outcomes and provide great clinical insights to the surgeons in future.
Thank you so much for that. And I think I totally agree with you about the decision support that's coming through, the navigation support, making surgeons, I guess, more efficient in their workspace, etc. I think all of those things are going to be an amazing contribution to improving the outcomes for the patients. So to the audience, in about 15 minutes time, I'll be coming to you for a Q&A. So do feel free to put some questions in the chat so we can start asking our esteemed panel some of these questions that you might be wanting to know the answers to. So we mentioned earlier in this webinar around emerging categories and kind of the next kind of use cases. If you look at the history of robots in surgery, obviously it's driven by urologists, first of all, for prostate surgery and for urology. We then went on to kind of colorectal and gynecology as the next specialties. We're seeing ENT, cardiac now becoming available. Of course, orthopedics has had its own robot for quite some time. So what are the next levels? What are we seeing next? Rob, coming to you.
Yeah, I mentioned diversification at the beginning. So we will see that diversification of systems, and some will draw on the systems that are already mature. So if you take interventional oncology, that's a nice example. So the way the emerging systems in that area work, the robotic arm controls the placement of a percutaneous probe that's placed through the patient's skin to the target organ so it can treat a lesion. It does so in a way that's very similar to the way the systems in orthopedics work. So it's navigated. There's a robotic arm like many of the competing systems to think surgicals. There's a preoperative plan, the software that controls it. So the systems that are coming through in interventional oncology draw very much on existing products. There are other areas where the systems have to be quite different. Neurovascular is a really interesting area. And that's where surgical robotics is being used by neurointerventionists to navigate to the clot in ischemic stroke, perform a thrombectomy, and make the procedure of navigating to that clot much easier. And so that's a robot which has to feed a catheter up through the patient's vasculature to the right point. It has to navigate through all the different branches, and actually AI can help there. Many of these systems navigate with the use of external magnets. So the magnet is on the end of a robotic arm, and that's controlling the movement of the catheter. So that's a very different type of system. And I think that's what we will continue to see. We'll see that diversification in the format of these robotic systems so that they're applicable for many, many different applications.
Thanks for that. And I love the fact that you gave a great example of intravascular robots, basically. We're moving to the world of Fantastic Voyage, it seems, from back in the 60s, that film that we all watched many years ago, of course, and thoroughly enjoyed. Mark, of course, you've been deploying robots for a while. You've seen the use cases, you're collecting the data and the literature, and of course, research around it. What excites you about which area we might see next being deployed with the Versius or other robots?
I mean, rather, I always say that we are the next generation robot. We've already gone that extra step. We've got the different arms, we have the different size and so on. And we have 5 mm instruments, which obviously are in the patient's interest. Luke and I, my co-founder, have about 600 on our wish list of what we want to develop. And some of it I can't speak about now. But simple things like getting rid of cables between bedside units. Because you're modular, you can have different sized bedside units. So if you had a very a piece of equipment you need with real strength to drive motors, you could perhaps have one bigger arm and the others all small. Those are just iterations along the line. We are going to see, I'm already seeing real advantages, and this comes to what was said earlier. We doing work in the transoral space in research and in pediatric space and thoracic. These are small spaces to be operated on, and one starts to see real advantages. And of course, that will generate the production of unique instruments. And really, we have one of our graspers where with software, the surgeon can decide how strongly it grasps. So as they go to different tissues, they can have a weaker grasp for more fragile tissues and a stronger grasp when that's not a problem. So I just see iteration after iteration coming. We've already seen massive advancement in insufflators, which is driven because you don't want to drop your pressure in a robotic case because it means resetting the arms. But so you see better insufflators, and we've now been looking at one that actually can identify anastomotic leaks with about 99% accuracy. So it's that getting that precision. And then the final thing to me, the thing that drives me mad or drove me mad about surgery is lack of standardization.
Yeah.
And the robot puts an interface between the surgeon and the patient, and that actually can force you to follow a standardized pattern, which ultimately is way better for the patient. And then when you've got all these big analytic sets, I was phoned from a hospital where they'd had 3 identical complications and had suspended their robotic program. And I was able to phone them within 2 hours and give them the data on 297 exactly the same operations done elsewhere with no complications. And we've subsequently worked out that it was an aberration, it was a fault more with them than with us. So I just get so excited when I see these things. And then, of course, when I've got a data set of 100,000 cases, then we can pull out all the anastomotic leaks, look at the videos, see was there any commonalities, anything we could prevent. And then finally, my robot is going to have a function one day that it will switch off all radios, all talking, and all music in theaters. So you can live in peace in the theater and concentrate on the job.
Don't be silly, Mark. That's never going to happen. We'd rather go back to laparoscopic surgery, if I'm honest. I'm just kidding, of course. I'm just kidding. All right. So thanks for that, Mark. And standardization is important, of course, in surgery. We have something in the UK called Getting It Right First Time. It's called GIRFT. Is brought in because of the variation across surgical practice. And that was an attempt to standardize practice and procedures across the UK, which had a great impact into improving outcomes for our patients. So variation is a huge problem, not just here in the UK, but on a global level. I'll move the conversation slightly different now in terms of the concept of remote work. And if you go back just before COVID, 2019, in fact, if you go back to the year 2000, that's 25 years ago, Jacques Morosco and his team were doing a laparoscopic cholecystectomy from ERCAD, for example, where a patient was operated from New York to Strasbourg or Paris. So it was a transatlantic operation. It was a lap cone. I remember watching it thinking, wow, how amazing that they could do an operation transatlantically. fast forward about 20 years, 2019, just before the COVID, a surgeon in the eastern province of China was using a robot and 5G technology to do remote surgery. So now we're seeing robots, remote surgery, connected surgeons around the world. In your experience, Stuart, have you seen much of this? Have you seen what's going on in the world of perhaps remote telemedicine or telesurgery in the world of orthopedics, for example?
Yeah, I mean, there have been some some pilots, if you like, and there's been some some hype around that. I really personally, and as a company, we don't see that as an important aspect of the future of orthopedic robotics. Orthopedics is much more of a hands-on sport than maybe some of the soft tissue surgery that we're talking about today. More often, the conversation in orthopedics is around how much task autonomy is going to be handed over to the robot in future, and to what extent can task autonomous or non-task autonomous robot extend physician reach in terms of their surgical volume. One of the biggest challenges facing orthopedics, particularly here in the United States, is the demand for joint replacement surgery outpaces the provision of trained orthopedic physicians. So this conversation about technology extension and technology acceleration of the available surgical community is much more relevant than the conversation around medicine facilities or capabilities.
Thank you for that. Rebecca, in terms of your instrument, which areas are you thinking about deploying it first and foremost? Which kind of specialties are you highlighting or targeting in your first kind of deployment?
We are trying to be as versatile as possible in terms of that we can hit everything within the abdomen.
Okay.
Mainly because we look at indications outlined by Mark CMR machine and intuitives, and when you go through all the indications on the FDA clearances and the regulatory clearances, the list is long, and there is the need for it to be a one and all. And I think that's a lot with a lot of the technologies out there, they need to be multifunctioning, and I think that's going to be a huge push moving forward to us. We need to grasp, we need to cut, we need to dissect, we need to seal vessels. To be accepted by surgeons, we need to be all of the above. And in fact, we need to do it equivalently, if not better, than the straight stick ultrasonics or the dexterous ultrasonics.
Thanks for that. I think the next question is really around, I guess, thinking to do some blue sky thinking. If you think, I wrote an article a while ago called The Surgical Singularity. At what point could robots not replace us, but augment us to a large extent, become autonomous? And I kind of wrote that about 5 or 6 years ago, thinking at what point would a patient accept a robot doing part of the operation autonomously? So I'd like to get your thoughts on that from a philosophical point of view, if I can, Rob. Is the public ready for this? We talk about robots, it's scary for our patients. We talk about robots and autonomous surgery and doing things on their own. They're not quite ready, I don't think. I'd like to get your thoughts on the perception and what we need to do to allow robots to become more autonomous to support us in our work.
So I think we'll ease our way into it, and we'll have to ease the public into the idea of it. So like much of innovation, that there are stepping stones, and you progress to that kind of vision that we might have for a long way in the future. So some steps along the way would be automating subtasks within a procedure, where the surgeon's still very much in control, but say you're automating suturing between point A and point B that you determine. That's an example of a step along the way, and I think another example which is probably further along the way is full automation of the procedure, but automation to predefined surgical plan. And that's probably best suited in orthopedics. In fact, it's been done in orthopedics back in the 1990s. But there, you're not giving away full autonomy to the robot. The surgeon is very much in control of the procedure because it's your pre-surgical plan that you've defined. And the robot is then implementing that plan when you have very precise control of the spatial environment. So works in hard tissue where you have fiducials in hard tissue, which means that the robot will exactly deploy that pre-surgical plan just where you need it to be in the patient, and nothing's going to move. So there are a couple of steps along the way to that ultimate vision, and I think that's how we have to approach it in terms of bringing many different stakeholders along the way.
Sure, and I totally agree with you that. I think it should be incremental. Mark, what are your thoughts around telesurgery number one, using robots? I know that in China they're doing some apparent hysterectomies from province to province now using robots and 5G and perhaps even 6G and 6G technologies. And then the question of autonomous surgery supporting, for example, going forward. I'd love to get your thought on CMR on that.
Yes, so let's start with remote telesurgery. I'm still old-fashioned. I quite like the idea of having my surgeon in the same room as me when I'm being operated on.
Don't
But
be silly. Don't be so silly.
but
That's so
telesurgery is doable. It's not difficult anymore, and it's certainly being done. One of the places I see it hugely useful, we use remote telementoring when a person is starting, where the surgeon could just say, the mentor could say, could I just take over for 5 minutes? I would push there or I'd push there. So it could make surgical teaching, it could take it up to another level with people coming from far. Telesurgery, on the idea that you don't have proper doctors in one area who can operate. Now, the first is you have to provide them with a robot that's identical to yours. Number two, that doesn't provide them with the perioperative care that they need to learn as well, or the intensive care unit. So the idea of a first world surgeon helping a third or low and middle income country doesn't come right, because it's all the other structure which actually goes around making it a viable option. And then the last one is we're short of surgeons in the world. So a surgeon in New York who's already working 70 hours a week, will he or she want to get on a robot late at night and start doing surgery in another country? So to me, I think at the moment there's a hell of a lot of hype around it. And I think we need to get back and have a sensible surgical conversation, taking all those features into account. In terms of autonomy, I agree 100% with Rob. We're going to have to persuade patients. But with a soft tissue robot, we have one imponderable, which is respiratory movement. And the response of organs to respiration is variable. Your bowel doesn't move according to a pattern. So how would you prescribe your instrument to actually follow that? So I personally am not convinced in my lifetime we will see fully autonomous surgery in soft tissue, but we will see stages that are automated or made more efficient. That's where I sort of be.
Well, thank you for that, Mark, that clarification. I remember seeing a video just recently. I'm not sure you saw it, Mark. I think I shared it on one of my social media posts around a robot training itself on videos on suturing, showing that it could train itself, given the fact that you use videos to help support it through learning and making errors. I thought that's fascinating. Robot training a robot. But that's another discussion.
Shafi, that's why we've kept all our videos. We've had permission to, because in a few years' time, something like that will be such a repository of data. And that's when, yes, you can start, machine learning and so on.
Of course. Thanks for that. Okay, I'm going to the questions now. The first one is from Ludmila Borges, who says, do you think in the future it would be possible to exchange data between systems so we can have an integration of decision-making supporting the decisions? So I'll go to you, Rebecca, for that perspective, because you're into your data at the moment. How do we integrate all that data from your instrument, from Mark's computer, from the OR? Is it going to happen?
I think it's going to be really tricky, but I think it must happen. part of our plan is never to be the kind of final production of our device. We describe ourselves as the fingernail on the end of Mark's arm, if you want. So we will be integrated within that system. I'm not sure if there was a question there on whether different robotics platforms were going to speak to each other. That's
Yeah.
a much trickier question to
That's
ask
much
because
more
it's a
contentious, I
huge,
think. We come to Mark in a
it
moment on that
is.
one. Yeah.
It's
We should make them open source. Is that we should do like a deep seek and disrupt the whole of the world of robots. Stuart, what are your thoughts around that? Do you think we can integrate? You've been this world for quite some time. What are the barriers to integration?
Just the normal competitive tensions that exist between very large med tech players who only see risk and not opportunity in that data integration. Orthopedics is a particular case study where you have an implant, a high value implant associated with the procedure, and you have a robot associated with the procedure. And the knee market globally is well over a $10 billion market, and it's a very high gross margin market. So you can understand that the big players in that market see the robot more as an enabling technology that supports their market share and profits that come from this implant market. What we're doing at Think is one step towards democratization. We are not an implant company. We are only a robot company. We live and die by the performance of a robot. And we are disconnecting the decision between the robot and the implant. And our end game is to be able to offer the best robot, which is we believe is ours, and allow it to be used with any implant out there in the world, whichever implant the surgeon believes is right for them or right for their individual patient that they're treating. Now, obviously, we've got a lot of competitive tension that we need to work our way through, but we believe that we'll get there. And we believe that when we get there, it will be good for society, it'll be good for the physician community at large, and ultimately good for patients. You know, Mako's the most prolific hard tissue robot in the market, but 60% of the surgeons that use Mako will tell you that they really would prefer to use a different implant and not the one that's provided by Stryker. So they're making a clinical compromise every single time they use that robot. And I don't think the future we should tolerate clinical compromise. I think physicians should have the opportunity to use the right technology and the right implants to achieve the best possible outcomes for the patients. So I come at it from a different perspective, but the democratization will be different in hard tissue versus soft tissue. But it's a great question.
Thank you so much, Stuart, for that. And thank you for the clarification on that. And you're right, we shouldn't be using what we don't think is the right apparatus or right technology or right implant. I think that's a very important point to make. And that also gives us this whole kind of variation that we discussed a little earlier. A lot of questions. I'll try to go through as many as I possibly can in the time that we have left. Let me go and pick one. So, Amin, your question around will surgeons be sitting or standing? They're all sitting in robotic surgery. We don't know one stands anymore because you're a console, apart from Mark, maybe. Mark,
we can stand or sit.
You can stand or sit. But most people now, the advantage of robotic surgery is you have a console, you can sit down, you have a cup of tea if you need to, you don't have to scrub up, and you can actually do the operation in a more comfortable manner. The only question is, how do you see it? Do you have to wear glasses or no glasses? And what's the vision like? And the video screen, for example, that's a question that most people ask around the kind of the ergonomics of surgery. Let's go through. Okay, so Harris, Bella, will robotics completely eliminate the traditional open surgery, and how will that assimilate in the traditional training programs? Mark, I'm going to see that one really, because people ask that question all the time. As we train more and more robotic surgery, do we lose those skills of open surgery, which can be very difficult in abdominal surgery, which I perform, where it can be quite complex? So that's a question that I get often asked around the world.
Well, I think one of the shames of laparoscopic surgery is that it only serves 40% of the population, and it should be much higher given all the advantages of minimal access surgery. We will never transition completely away from open surgery. There are certain surgeries which actually do better open than even minimal access. And there are some surgeries that are not able to be done easily robotically, which will still say. So we'll still, but I used to sponsor the Association of Surgeons in Training, and 99% of them have an expectation they'll work on a robot. And I'm not as fussed about whether they lose their laparoscopic skills or not, because I have the generation. I started in laparoscopy. By the end of my career, I don't ever know when I had to convert from laparoscopy to open, because we could do everything laparoscopically. And if I did convert, I used to regret it. So I do think we will see a massive increase. I think we'll see a drop in a minimal access standard surgery, and there will still be a residual of open surgery, but it might go down to a smaller number, and that's when you get your supervisory roles again.
Thank you so much. Let's go through some of the other questions. So Evan Geller, you talked about being entrapped by a robot company. I think Stuart answered that question, that you can be, because obviously that implant they were describing with the maker, you have to use the Stryker model, and actually that's a barrier. But hopefully we can overcome some of that. On the other side, robots do standardize, as Mark mentioned earlier, around reducing the variation across operations. So I think there's two parts to that question. I guess the next question is about which I was going to ask anyway. We've got, I think, a couple of people from other parts of the world being asking questions around democratization. How do you disseminate it? How do you deploy it? Is it going to be cheap and affordable? And that's a question, I think, for the larger community. We know robots have come in. We know they are here to stay. Is how do you now deploy those in other countries? I'd like to get your thoughts, Rob, around that. Should we be doing as an industry? Say, hey, these robots should be available on a global level.
Again, I think it's worth looking at the different formats of robotic systems that are available and how they allow existing equipment to be used. So there is a new format that's been emerging in the last couple of years, which people call by various names, but you can think of it as advanced laparoscopy, where the robotic system just controls the laparoscope, and it typically controls through one other port, and that's typically a soft tissue retractor. And then the surgeon is then using straight stick laparoscopic instruments that they already have. And that's being proposed as a lower cost entry into robotics, a way that can make use of existing instruments and systems that are in the hospital. And actually, I'd love to hear Mark's take on that, because that's in the very same market that Versius plays in. And I'd love to hear your thoughts.
Well, I think just to clarify one thing, Rob, we play in all the markets. We can do esophagectomies, pancreatectomies, etc., etc. So the complex surgery is very much our play as well. I was very keen that we deploy in low and middle income countries as well. And my busiest robots in the world are in Pakistan, in Karachi. So I think it is about keeping costs down, and I prefer my company ultimately to make money from volume of sales rather than margins in sales. So more people getting it and not just inflating a margin on top of it. But the other thing about our design, that's why we went for modular and small, is you can choose with our robot to do as much or as little as you want robotically, and as much or little as you do laparoscopically, because the ports are all identical. And a good example there is staplers. I chose not to build a stapler because the literature on staplers shows real complications. And there's just some papers coming out now where Ethicon and Medtronic are showing that their staplers handheld are cheaper, more efficient, less anastomotic leaks than certain robotic staplers, and therefore leaving the surgeon with the choice to make a choice for the patient rather than just slavishly use what that system has on it. So I would agree with Stuart as well. I think it's got to be about what the best students are. And that's where a system like ours is completely defined. You can use it in any way you want, totally robotic or a small part of it robotically. And so I think that is an important market, Rob. And the other thing as well is for the more simple ones, you may just use the robot to suture and do the rest laparoscopically. But what we do find with our surgeons is as their experience grows, they do less and less hand and they do more and more robot.
Great, thanks, Mark. Question for you, I guess, Rebecca. They talk about the engineering challenges of building things in robotics. What are the challenges that you've faced in your kind of journey so far into deploying these instruments into practice? I'd love to get some thoughts on that.
It comes to probably the reason why I'm here today, that to develop these tools, to develop the robot, the feedback from the surgeons is paramount. So having the nuances, how they use it, how they feel about it, and thus what hopefully the result is they take it into their surgical theatre and they use it and they're happy and confident that this patient outcomes are right on the other side. That's hugely important to us. And we're a very small we're a very small company. We don't have big budgets. We certainly aren't going to start paying people per surgery or per time they spend an hour with us. We just don't have that bandwidth. So that's of course going to be a huge strategy to us. Another one was, which I implied earlier, is that we are, as I say, the fingernail to the robotic arm. We also aren't going to buy a robotic arm or a robotic system to bring into our office, for the same reason that the systems aren't available worldwide. It's a huge capital outlay for most people, which continues to be a barrier.
Yeah. Thanks for that. Thank you for that. And there's always a challenge as a startup. We love startups. We love people developing ideas. We support them in all my communities that I work with. So we wish you luck on your journey. Last quick question on sustainability. There's been a lot of discussion recently around how do we make surgery more sustainable. Sustainable group, I think in Birmingham, did the world's first operation that was a net zero. So I think this comes to you, Mark, I guess. Sustainability, is that something that's on your mind at the moment? Do you build it into your plan, or is it something that you kind of think for another day as you deploy more and more on a global level?
No, 100% on our mind. So even from building our factory so that we get all the appropriate measures to reduce carbon output. Things like making instruments multi-use and reusable and going away from the single-use market. But of course, if we really are going to make an impact on sustainability, one of the things that worries me the most is the way the theatre is set up. I mean, at the end of each case, there's one of my previous inventions could have fitted inside this phone. When it came back from the company I'd sold it to, it was in a box about that size with polystyrene and plastic and everything else. And so we've got to get away from that sort of better packaging, neater packaging, better drapes, maybe, and I think we have a huge responsibility because it's not just sustainability, it's also about creating a value-based system, and dropping the cost so that the people in low and middle income countries can benefit from these technologies.
Great, thank you for that. And that's, I think, coming to the end of our webinar. I'd like to thank the audience for the amazing questions. Thank you for the participation and for joining us on this evening here in London. I'd like to thank, of course, our esteemed panel for their valuable insights. I've certainly learned a lot over the last hour or so. Thank you to Mark, Rob, Rebecca, and Stuart, and thank you for joining us. Our next webinar will be in a month's time, and please go to our website and register for that in the next few weeks. Thank you so much, everybody.